So now we will start our lecture. Very important topic today: how to approach an adult patient when patient is having nausea and vomiting. Basically, in the palliative care setting. So this lecture will be taken by Dr. Rakesh Gargh. As we can see that Dr. Rakesh, so many degrees, I think this says that Dr. Rakesh is one of, I'm very proud that he is one of my colleagues. He is additional professor in our department and he is a true academician, always extremely interested in any academic activities which is happening in the department or in the institute. And he is a good teacher, always teaching resident doctors. And besides this, there is a lot of important things to say about Rakesh, that he has got almost 200 publications in various national and international journals, and he is also associate editor of two important Indian journals, that is Indian Journal of Anesthesiology and Clinical Pharmacology and Indian Journal of Anesthesia. He is also sometime organizing or sometime as a faculty in various workshops, and I have seen him that he is attending a lot of workshops on airway and mechanical ventilation and CPR workshops as a faculty. Besides this, he is also attending the conference lectures on pain and palliative care. And we can see these two awards which he received in 2018 and 2019. In 19, he has received Indian Association of Anesthesia Proficiency Award, and in 2018, he has received a Bhopal Award 2018 for academics. So, with all these words about Rakesh, I think we can see that he is a excellent academician, and hopefully you will be able to learn a lot in the area of nausea and vomiting in palliative care from Rakesh. So Rakesh, thank you, and we can start.
Thank you so much for your kind words, ma'am. I bring greetings from the All India Institute of Medical Sciences and happy Guru Nanak Jayanti to everybody as well. So when we say about the nausea and vomiting in palliative care setting, we know that almost two-thirds of patients will have nausea and vomiting in patients who are having cancer. And not only with cancer, but when we talk of the other chronic disease with terminal illness, almost half of them will have sometime the episodes of nausea and vomiting, which can be distressing to these patients as well as to the caregivers as well. They affect the patient's daily functioning and quality of life. So it becomes very important to understand the mechanism and this optimal management so that these patients have good quality of life, what we are targeting always in the palliative care setting. The palliative management is important for these patients, and if we diagnose and identify the mechanism, majority of time we'll be able to manage this nausea and vomiting in majority of our patients. Now, when we say the terminology of nausea and vomiting, the nausea is defined as an unpleasant sensation.
Rakesh, slides have not started. Your slides.
I'll do it again, ma'am.
Yeah, this is sorry, the slide has not.
Is it coming, ma'am?
Yeah, it's coming now. Okay, go ahead.
So in majority of patients will be able to manage this nausea and vomiting if we can diagnose it timely and use the appropriate management tool. We'll be able to manage nausea and vomiting in majority of these patients. The nausea and vomiting, we define nausea as the unpleasant sensation of imminent need to vomit, which may not be ultimately leading to vomiting. So this is the patient say that they have a nauseating sensation. And the patient feels that they have no desire to eat or drink because of this sensation. They may refuse treatment even, including the analgesics, which again leads to deterioration of the patient's quality of life. And it has a lot of psychological stress. On the other hand, vomiting is the observable neuromuscular reflex. This means that there is a forceful oral expansion of the gastric contents to the mouth. And this leads to pain aggravation, refusal to eat, refusal to take analgesics and the other treatment, thus affecting the palliative management and the cancer management, and patient feels a lot of dejected. At times, patients also use the term retching, which is the muscular activity of the abdomen and thorax, often voluntary, leading to forced inspiration against a closed mouth and glottis without oral discharge of gastric contents. So this is what the domain of nausea and vomiting would come up, and the patient will define them. And if you see the etiology of the nausea and vomiting in general, these are the various etiologies that we can remember by this mnemonic of 11 M's. And many of them would be seen in the cancer patients at some point of the manifestation of nausea and vomiting. And that is how we need to identify them and treat them appropriately, because each of them will have some difference in the management. Each of them will have some difference in the choice of drugs that we'll be using for these patients, which I will be coming in the subsequent slides. So we need to look for the signs of metastasis, the meningeal irritation, the movement-related activities, the mental anxiety, which is an important component in cancer patients, the medications that are they being administered, the irritation of the mucosa, for example, the gastric irritation, the mechanical obstruction that can happen in metastatic cancers or the primary cancers of the GI tract, the motility issues which can happen because of the cancer per se or the drugs that we use, the metabolic abnormalities, the infections, and at times the cardiac dysfunction also. Of these, the most common reasons for nausea and vomiting in a palliative care setting includes the anxiety, the pain, the gastric status or the gastritis, the obstructions, the constipations, the use of drugs, which includes not only the analgesics like opiates, morphine, but also the radiotherapy and chemotherapy as a part of treatment management for the patients with advanced cancer. They could also be because of the brain tumors or brain metastasis leading to raised ICP, and there could be other regions of the abdomen that can lead to the nausea and vomiting, in addition to the metabolic abnormalities. Before we proceed further, let's see the pathophysiology, that why this nausea vomiting happens and what are the factors that control the occurrence of nausea and vomiting when patient is being managed in the palliative care setting. Now, these are the 5 areas wherein the integration happens for occurrence of nausea and vomiting. The stimulus could be from the cerebral cortex, or it could be GI tract. It could be from the vestibular apparatus, or a chemoreceptor trigger zone or the dorsal vagal complex, again a part of the brain itself, including the brainstem and the medulla. Now, when we say these components, these are being stimulated by various sensations that can lead to the elicitation of the vomiting center finally, which is a central pattern generator for the occurrence of nausea, vomiting. And these stimuli that leads to nausea, vomiting could be, if it is in the cerebral cortex, it could be the sensory input. At times, it could be pain, smell, or sight. It could be anxiety, which is one of the phenomena seen in palliative care patients, where they have anxiety about the disease and the disease progression. It could be because of the brain tumors or metastasis leading to meningeal irritation and increased ICP. The stimulus from GI tract could be because of the serotonin release from the gastric or the GI mucosa enterochromium cells. They can also be because of obstruction or stasis or inflammation in the GI tract. When talk of the chemoreceptor trigger zone, which is having an absence blood-brain barrier, so any drugs or metabolic abnormalities can directly elicit or stimulate the CTZ, which can lead to the stimulus or the elicitation of the vomiting center, leading to vomiting. Even the vestibular apparatus, which could be because of the CNS lesions or opiates, can also lead to the stimulus and can lead to the vomiting. So these are the centers which are involved into the occurrence of vomiting. And as we can see that in a palliative care setting, many of these can happen at various points in the journey of a cancer patients or a chronic disease patients. And that is why it becomes important to understand these sensory stimuli, because at different point of patient's management, different stimuli can happen, and that will decide that what type of management would be required for these patients. And these managements would depend upon the action on the various receptors that are present at various sites that I have just described, which includes cerebral cortex, GI tract, vestibular apparatus, and the CTZ. And these receptors are differentially located in these areas, and that's why it becomes important to understand that which is the primary area which is getting stimulated for the occurrence of nausea and vomiting. For example, in CTZ, it will be neurokinin primarily, it could be dopamine and serotonin receptors. If we talk of the vestibular apparatus, it will be histamine and acetylcholine muscarinic receptors. If we talk of the GI tract, it is primarily the serotonin, the neurokinin and the CB1 receptors, and these are leading to finally the occurrence of nausea and vomiting. Now, in this diagram, we can see that when these receptors are activated by the various stimuli, they can lead to the increased salivation, they can lead to the abdominal muscle contraction, the relaxation of the lower esophageal sphincter, the diaphragmatic contraction, and the retrograde contraction of the GI tract that finally leads to vomiting. So this is how the pathophysiology of the vomiting happens in patients who have stimulus from any of the places that we have just discussed. Now, based on these receptors, I'll be coming in detail later how to choose these drugs. But as I mentioned that dopamine is one of the receptors, so we can use dopamine antagonists like haloperidol, which is the one of the commoner drug. We can have histamine receptor blockers like denphenhydramine or promethazine. We can use the acetylcholine antagonists like scopolamine, or serotonin antagonists like ondansetron, or longer-acting drugs like granisetron or palonosetron even. The neurokinin 1 receptor antagonist, which is one of the emerging drug and has found an important role in the management of nausea, vomiting in cancer patients, which includes aprepitant and the newer molecules related to neurokinin 1 receptor antagonist. We also use prokinetic agents like metoclopramide. At times when there is a gastric irritation because of acidity, we can use antacids. And the other agents that have found its role for the management of nausea, vomiting in palliative setting include steroids, specifically dexamethasone, and octreotide, especially in conditions where there is increased amount of secretions leading in the background of obstruction. Now, a patient who comes with nausea, vomiting, this nausea and vomiting can happen at various points. It could be acute because of any stimulus. That is within 24 hours after any cancer interventions, maybe the administration of drug therapy or radiotherapy or occurrence of any acute event. It could be delayed more than 24 hours after any cancer interventions. That is called delayed M-Esis and can be seen in like administration of chemotherapy and radiotherapy. Anticipatory. Now, this is an important event which is primarily related to the cerebral cortex, related to the phenomena of anxiety. And this can happen before any cancer intervention. And this needs to be controlled as well because this can have impact on the patient's management. There could be breakthrough nausea, vomiting, which happens within 5 days after getting the medications, and hence it emphasizes the need of patient's follow-up as well. And at times, the treatment of nausea, vomiting is not SOS. It has to be planned, and patient needs to understood so that they can have a follow-up so that even this breakthrough nausea, vomiting does not happen. At times, patient may have refractory nausea, vomiting, where patient will be not responsive to the conventional anti-nausea medications, and hence we need to use the combination of various drugs and simultaneously, which again will be applicable to other aspects also, the management of underlying etiology or underlying reversible cause that has leading to nausea, vomiting. And at times, a patient can have persistent nausea, vomiting, which can last for days to weeks. And these patients would require the use of antiemetic drugs for a longer duration with simultaneously management of the underlying etiology if possible. Now, having said that, we have understood that why this nausea, vomiting is happening. It is an interaction between various receptors and its communication with the vomiting center leading to vomiting. Now, the treatment of nausea, vomiting is not empirical, or the choice of drug is not uniform across the terminology of nausea and vomiting, but it is mechanism based, and we have understood that it can happen through various sources in the body. So it cannot be generalized. We need to identify the cause and thus relate them into mechanism based. In a palliative care setting, the pathophysiology of nausea, vomiting could have origin from multiple receptors that also needs to be remembered when we are managing these patients. For example, a patient may be receiving the analgesics, maybe having the obstruction, maybe having the brain metastasis, maybe having the anxiety as well. So when we are managing these patients, a comprehensive assessment of the patients is desirable so that we can provide optimal nausea vomiting management for the patient to improve his quality of life. Now, when we see two approaches, which has been conventionally described, and the management strategy is based on these two approaches primarily. One is the mechanism based and the other one is the empiric. The commonly or the acceptable method always remains the mechanism based, which determines the underlying etiology and target medication is given for this etiology. And it is effective in majority of patients, and we need to assess all causes systematically using appropriate tools and the administration of drugs accordingly. In empiric therapy, usually, as I mentioned earlier, the palliative care setting, patient can have multiple etiologies. So that's why based on the most common etiology, the drugs can be initiated, like for example, say serotonin antagonist or dopamine antagonist, regardless of the underlying etiology. This is not the usual pattern, but at times it may be required when the patient is not amenable to the assessment of the etiology. In those situations, it could be considered as a rescue measure, but the mechanism-based approach remains the acceptable method. When we say the mechanism-based approach, it requires a thorough evaluation to have differential diagnosis. The differential diagnosis needs to be narrowed down based on the assessment, history, examination, and if required, maybe some amount of imaging, which will narrow down the differential diagnosis. This will help us to determine the underlying pathology and the neuroreceptors involved, and this will help us to choose a specific drug that will target that neuroreceptor which is responsible for nausea and vomiting. The antiemetic, when the patient is having nausea or vomiting, it should be round the clock till it is controlled by appropriate titration of the drugs. And once it is controlled, then it could be tapered off if the underlying etiology or the underlying reason is a reversible one and has been managed. If the nausea persists even with the maximum recommended dose of the antiemetic, we need to look for the additional reversible mechanisms and treat them. So this is the basic overall view of management of patients who comes with nausea and vomiting in a palliative care setting. Now, when we say the assessment of these patients, it becomes understand to assess so that we can have a differential diagnosis. We need to look for the onset of nausea, vomiting. When did it begin? How long does it last? How often does it occur? Is there all the time, or it is being initiated by some provoking factors? What makes it better? What makes it worse? And the patient also needs to describe it, that what is the quality of the event that is happening. And if patient can describe, this becomes important, because first, for example, patients have, say, projectile vomiting, then a differential diagnosis of something wrong with the cerebral cortex can be taken as differential diagnosis. Patient can also be asked about the reason. Do you have nausea with or without vomiting? And that becomes important at time, that it is primarily irritation or it is irritation with a lot of muscular activity because of the underlying reason. Severity also needs to be assessed, and at times patient may be taking some drugs which can cause nausea, vomiting, or patient may have taken some drugs in the past which is being used for nausea, vomiting. That will also help us to make a diagnosis. We need to look for the impact of this event on the patients, and we need to assess at what comfortable goal or acceptable level for this symptom patient will be accepted. So we need to give them a realistic hope when we are managing these patients, because at times the cause or the underlying etiology may not be fully reversible, and that's why we need to have a realistic goal, and that's why we need to assess this as well. Now, when we are assessing it, even the symptoms will give us the broad domains that I earlier mentioned about the underlying etiology of the nausea, vomiting. If a patient says that they have intermittent nausea with early satiety, postprandial fullness or bloating, nausea relieved with vomiting, small amounts of undigested food, this means there is some reason with the abdomen, with the GI tract. If patients have intermittent nausea with cramping and altered bowel habit, and nausea is with large M-Esis, sometimes even bilious or feculent, this indicates there is some obstruction in the GI tract. If a patient have persistent nausea aggravated by sight, smell, and unrelieved by vomiting, this means there is some underlying chemical cause. Chemical cause, I mean the drugs, maybe like opiates, like morphine, or it could be chemotherapy induced as well. If a patient says this early morning nausea and the vomiting is associated with headache, this means there is some issues with the cerebral cortex, could be because of primary tumor or metastasis. If the nausea is aggravated by movement from the degrees of turning of head to motion sickness, this means there is some lesion with the vestibular component, which could be a central lesion, or it could be because of the metabolic or electrolyte abnormalities as well. If the nausea and vomiting is associated with anxiety, it is more of a sensory stimulus from the cortical area, and that also needs to be taken care of. So this will help us to make a differential diagnosis when we are assessing these patients. The general principle, as I mentioned, identify the underlying etiology and try to treat it. And if there are some reversible causes that are causing nausea and vomiting, that also needs to be corrected simultaneously while we are starting them on antiemetic drugs. And the therapy may include pharmacological measures as well as certain non-pharmacological measures are also useful for management of nausea, vomiting. Now, when we say the management, usually in a palliative care setting, as I mentioned earlier, the reason for occurrence of nausea, vomiting could be multiple. So that's why, depending upon our assessment, we can use a combination of drugs. Simultaneously, we also need to remember the route of administration. When a patient is having active vomiting, the administration of oral drugs may not have absorption appropriately, and hence the control of nausea, vomiting may not be appropriate. So if a patient is having persistent vomiting, we can use an IV route preferably. In a home care setting, a subcutaneous route may be considered. And once the vomiting is settled, we may consider the oral drugs for maintenance therapy so that patient does not have, as I mentioned earlier, the breakthrough vomiting or the chronic vomiting. Simultaneously, some of the drugs may have side effects. For example, if you start them on Perinom, that is metoclopramide, they can have extrapyramidal symptoms. Patients with the drugs like ondansetron or ganacetron, if they are given for longer duration, they can lead to constipation. That's why simultaneously we also need to look for these associated complications when they are being started. And when we start these drugs, we need to review the dose after 24 to 48 hours. And if they're persistent, we need to look for why the drugs are not active. Either we are missing some etiology, we need to reassess the patient and treat them. If the drug is appropriately controlled on parenteral therapy, we need to consider to convert them to oral after the vomiting is controlled. So I have to have persistent control of the nausea and vomiting. So this is just in summary. I'll be discussing these drugs in detail. When I say the metastasis, we can use some drugs. There is some issues with the cerebral cortex like anxiety. We can use anxiolytics. If it is related to the drug or the chemical cause like opiates or cancer therapy, we need to look for drugs like say haloperidol, or we need to look like for 5-HT3 antagonist. Now let's see this case management and try to understand that how can we choose the various drugs, antiemetic drugs, depending upon the underlying etiology. Now this is a 45-year female patient of CA breast with locally advanced tumor and bony metastasis. She is being assessed for further management. She presented for the first time, and the treating oncologist referred for the pain management. She presented with pain of severity of visual analog scale of 8 on 10. She was admitted with us and she was titrated to intravenous morphine and pain controlled finally on tablet morphine, oral drug, plain, 10 milligram every 4 hourly, and SOS, along with other adjuvants including paracetamol and gabapentin. She was discharged home with optimal pain control. She presented later with pain again, and on inquiry, she also mentioned the episodes of vomiting in the last 24 hours. Now, this means this is the patient of cancer, locally advanced, started on analgesics, but now she has vomiting. Now, when we say these type of patients who come with vomiting at this juncture, so probably it appears that this patient has vomiting when they were started on opiates like morphine. And the opiate-induced nausea vomiting is well known. The different mechanisms associated with opiate-induced nausea and vomiting includes the stimulation of the chemoreceptor trigger zone. It also increases the vestibular sensitivity and hence the chemical cause of the stimulation of vestibular apparatus happens in these patients, leading to nausea, vomiting. It can also lead to GI stasis and the constipation that again aggravates nausea, vomiting. So this means the opiate-induced nausea, vomiting is multifactorial, and hence we can see here that in the chart which we mentioned earlier, that the various factors that can stimulate the vomiting center are related to the opiate-induced nausea and vomiting. And that's why we need to choose a drug which probably would be active on all those receptors which are causing nausea, vomiting related to the opioid. So probably when we talk of opiate-induced nausea, vomiting, and we have just seen the receptors involved, the use of drugs like haloperidol or metoclopramide remains the first-line therapy for these patients. These patients need to be treated aggressively because once the vomiting happens, their pain manifests, they become more anxious, and they can have more nausea, vomiting. So this means not only the pain management needs to be done aggressively in these patients, at time it needs to have intravenous management, but simultaneously the use of drugs like haloperidol and metoclopramide, which will be having action on the three areas that we have just discussed, which lead to the optimal control of nausea and vomiting. So this patient was started on haloperidol oral 0.5 milligram HS and Perinom oral 10 milligram thrice a day. Patient has good pain control, and subsequently it was converted into oral therapy, and the patient was discharged with good pain and vomiting control. Now, when we say the opioid-induced M-Esis, we said that the haloperidol and the Perinom or the metoclopramide remains one of the modality, but at times patient may have very refractory type of nausea, vomiting with a single opiate analgesics, and sometimes the opiate rotation or the route switching may be an effective approaches, though we do not have very specific data for it, but this may be considered as a rescue measure in some of the patients who are not responding to the opiate-induced M-Esis. Now, the same patient had a good pain control, this 45-year female patient with CA of locally advanced tumor and bony metastasis. Now, the medical oncologist felt that she can be started on chemotherapy, and after receiving the first cycle of chemotherapy, she complained of nauseating episodes with vomiting as well. So for the management for these patients, probably now this appears to be the chemotherapy, and if subsequently patient receives radiotherapy, they have a emetogenic potential. And these type of drug therapies that the patient receives as a part of their cancer management, they can lead to nausea, vomiting. We also need to look for other differential diagnoses that can happen in these patients when they are receiving these drugs, like infections, electrolyte imbalances, or occurrence of metastasis to brain. That also needs to be considered. But primarily, if we see the chronology of the events that are happening and based on the patient assessment that we have mentioned earlier, this appears to be related to the chemotherapy at present. So when we say the chemotherapy-induced nausea, vomiting, it is primarily the receptors that are being activated at the chemoreceptor trigger zone, and that needs to be looked for. When we say that various drugs that are responsible for causing nausea, vomiting, it is not chemotherapy in patients with chronic disease requiring palliative care, but it could also be because of analgesics, antibiotics, or other drugs which are being administered for the associated comorbidities like metformin, antiparkinsonians, anticonvulsants, antihypertensives, and sometimes these patients may be for palliative surgeries, so they can also be related to the occurrence of nausea, vomiting in the perioperative period. When we talk of the chemotherapeutic agents, there are certain groups which has a high hematogenic potential, and the other drugs which have low. So we should be aware of these drug therapies which are given, and that's why at times the drugs which have a high hematogenic potential, where the chances of occurrence of vomiting will be more than 90%, like cisplatin or high-dose cyclophosphamide or decarbazine. Now, these drugs would require combination therapy of the antiemetic drugs so that the patient will not manifest nausea, vomiting. Patients can have the drugs can have moderate hematogenic potentials like carboplatin, cytarabine, doxorubicin, oxaliplatin, and some other drugs have low potential like the docetaxel, the pemetrexed, the gemcitabine, and other drugs like bevacizumab, vincristine, they have a low potential. So understanding the drugs that are being administered as a part of their chemotherapeutic regimen, which is a combination of drugs usually, we need to consider whether the drugs have high or moderate or low or minimal hematogenic potential, and hence will be able to decide the type of drugs that are being used. But we need to remember there are certain risk factors which we can easily assess. The high dose of a chemotherapeutic agents, the combination of chemoradiotherapy that is being delivered to sometimes these patients, the females younger than 55, patients with history of nausea, vomiting after previous chemo or radiotherapy, motion sickness or vomiting in the previous pregnancies or previous history, and associated fluid and electrolyte imbalance. So these patients are more prone even for minimal or low hematogenic potential of chemotherapy. They can have increased incidence of chemoradiotherapy induced nausea vomiting. We also need to consider the timing of occurrence of nausea vomiting when some patients is receiving chemotherapy. There could be acute phase and delayed phase, which I mentioned earlier, and then in between there could be breakthrough nausea vomiting also. Now, the choice of drug in these patients nowadays would depend upon the NK receptor antagonist, or it could be glucocorticoid, or it could be serotonin antagonist. So these are the drugs. But if we see here these three drug patterns, the use of NK receptor antagonist like aprepitant and the glucocorticoid, they are effective in the whole course of patients of nausea vomiting when they are receiving chemotherapy. On the other hand, the 5-HT3 antagonists are only useful in the acute phase of chemotherapy. So that's why we need to use the drugs appropriately when they are being administered as prophylactic, especially when high hematogenic chemotherapeutic agents are being used. The chemotherapy-induced therapies or the various drug-related factors, we can choose the drugs. So when we say of radiotherapy, usually the ondansetron, gadacetron remains the drug of choice. Chemotherapy, earlier the combinations was usually ondansetron with steroids like dexa or metoclopramide. But in the recent time, these drug therapies have changed because we have newer molecules like aprepitant, and more recently like the use of olanzapine, which has come into picture. And the chemotherapy management, if you see the NCCN guidelines in 2020, the management plan have changed. When we talk of the metabolic abnormalities, obviously the underlying manifestation of uremia or hypercalcemia needs to be managed as per the standard protocol, but haloperidol appears to be an acceptable drug for metabolic induced nausea vomiting. Now, these are the usual combination of drugs that are being used for the management of chemotherapy-induced nausea vomiting. We can, for high hematogenic drugs, we can use NK receptor antagonists with 5-HT receptor antagonists with steroid. But now, as I mentioned, the olanzapine is emerging as one of the drugs, and they have been mentioned as the first-line management of chemotherapy-induced nausea vomiting in cancer patients, and then they can be added on. This is usually a polypharmacy. These can be added on with a serotonin receptor antagonist with a steroid. So the combination of olanzapine along with granisetron along with dexamethasone appears to be an acceptable regime for patients receiving high hematogenic potential chemotherapeutic agent. For moderate category, the combination remains almost similar. The duration may be less. For low, it could be dexamethasone along with the dopamine receptor antagonist, or we can add on the serotonin receptor antagonist as a sole agent, which will be acceptable for these patients. Now, this is what I have just mentioned. When we talk of the high hematogenic potential, especially where the anthracycline and cyclophosphamide are not being used, the NK1 receptor along with steroids are the common drug, but I'll come a little later with NCCN also, where this was being used a couple of years back, 2-3 years back, but now with the addition of olanzapine, this combination of drugs are being replaced with the new regime, including olanzapine. In patients with receiving carboplatin, we can again use the combination of these drugs, but the NK receptor antagonists can be omitted for moderate and low. this remains a good molecule. The NK receptor molecule like aprepitant, frosprepitant, ropipritant, and olanzapine remains a very good newer molecule with very good effectiveness for nausea vomiting management in patients receiving chemotherapy. For delayed, again, as I mentioned earlier, the use of aprepitant is a good drug. For acute phase, the drugs like 5-HT3 receptor antagonists can be used, but for delayed nausea vomiting, the addition of aprepitant along with the steroid remains the acceptable technique for management of these patients. Again, the breakthrough nausea vomiting remains very distressing to the patients. So olanzapine is coming up as a good agent for use of breakthrough nausea vomiting management in these patients, and the continuation of the drugs of NK1 receptor antagonist also remains an acceptable choice. Now, this is the recent guidelines of patients who are receiving the anti-cancer therapy. The olanzapine has come into this picture, so I think we'll be sharing this slide so you can go easily. Olanzapine, aprepitant, and steroid. Now, these remains the combination of drugs for patients for acute and delayed nausea and vomiting when they are receiving the drug therapy. For moderate category, the 5-HT receptors, the longer acting agents like granisetron or steroids can be considered for these patients. So when we say for the breakthrough pain, the combinations of drugs, olanzapine has come into category 1 here. So olanzapine in the dose of 5 to 10 milligram may be acceptable. Coming to the radiotherapy-induced nausea vomiting, it depends upon the amatogenic potential of radiation therapy, which could be high, moderate, low, depending upon the area being exposed. And accordingly, we can use a combination of 5-HT receptor antagonists with steroid in majority of them. If they have a low potential, probably 5-HT receptor antagonist remains the good option. And this is again same which has been with the recent NCCN guidelines also. Now, coming back to our same patient, the female 45-year, her pain was well controlled. She was started on treatment for bony pain, probably have a bony metastasis. She was started on etorocoxib and in addition to the previous drugs, but now she complains of upper abdominal pain along with nauseating feeling. Now, herein probably the reason for this type of pain in these patients would be the irritation of GI tract, because we have started NSAIDs. So gastric irritation could be the reason for nausea vomiting in such patients. So we need to look for this and try to treat them accordingly. Now, for gastric irritations, usually the addition of proton pump inhibitor remains one of the options, but we can add on the ondansetron subsequently to take care of these patients for management of pain. And if you think because of the combination of drugs like opiates, we can think of addition of metoclopramide, and in refractory cases, even olanzapine can be added. Now, subsequently, this patient was nicely managed, but a couple of weeks later, she presented to emergency with projectile vomiting for last 24 hours. She has a vision abnormality. And on assessment and imaging, a cerebral metastasis with signs of increased intracranial pressure was confirmed. Now, this patient now, though well controlled on pain and vomiting, but now again have vomiting. So probably if you see these patients here, the involvement of cerebral cortex, this is the area which is being involved now with increased ICP that needs to be managed. So patients with raised intracranial pressure, we need to manage them acutely because they can have very difficult type of nausea, vomiting that cause a lot of discomfort to the patient. Dexamethasone remains the drug of choice. We start at 8 milligram this patient and can be given twice a day, but we can go up and titrate to even 36 milligram. But the use of 8 milligram twice a day is one of the options. These patients are also require the radiotherapy and an acute decongestion measure to reduce the intracranial pressure. By the time the steroids and radiotherapy is having an effect, we can start them on mannitol also. And recently, the olanzapine has again found a role in case of refractory cases of intracranial pressures that can be used for management of nausea, vomiting in patients with increased intracranial pressure because of primary tumor or metastatic tumor. The other reasons that we see in palliative care setting where the higher cortical structures are involved, it could be direct stimulation because of tumor, bleed, edema, infection, which can happen in patients who are immunocompromised, could be emotions and memory. These patients, the anxiety needs to be managed by good counseling, by understanding them a realistic hope, and we can also add them on dexamethasone so that the amount of edema decreases if it is because of the infection or edema or metastasis. When we talk of vestibular system, it could be tumor metastasis, or at times immunocompromised patients can have middle ear disease or even stroke because of bleeding issues in these patients. These can be mentioned very easily with scopolamine. Scopolamine remains the commoner drug that are being used for these patients. Now, the other important factor that causes nausea vomiting is the malignant bowel obstruction. Let's see this patient, a 57-year-old man, a woman with ovarian cancer, stage 4. She was well managed with surgery and chemotherapeutic agent, but subsequently she presented with nausea, vomiting. She was not able to tolerate any food. Last motion was 3 days prior, no history of constipation. And the CT scan shows multiple sites of partial narrowing of bowel, most prominently in proximal genome with air fluid levels. Now, this patient is having a malignant bowel obstruction induced nausea vomiting, which is commonly seen in ovarian and GI cancers. They can also be seen with cancer metastasis to abdomen, like in case of breast, melanomas, lung, and bladder. And these are usually seen in almost 50% of patients that come to a palliative care clinic. The underlying pathogenesis is usually a mechanical obstruction, which may be intraluminal or extraluminal, depending upon what type of cancer it is. If it is metastatic, it could be from outside also. At times, it could be functional obstruction because patient may have motility disorder because of the involvement of various neural components, and that's why at times it could be paresis as well. The approach could be, depending upon the assessment, it could be a surgical approach, which is usually considered for these type of complete obstructions, which are primarily because of cancer leading to obstruction in these patients. But if there is a carcinomatosis, the role of surgeries remains very restricted. This is a good systematic review where they have found that the palliative surgery for malignant bowel obstruction from carcinomatosis does not lead to much improvement in the quality of life, and as such may not be advisable. In some situations, we can consider placement of stent for the symptom reliever, and the self-expanding metallic stents remains one of the options that can be considered, especially in gastric outlet obstructions or duodenal or large bowel obstructions. The more distal obstruction and shorter length of obstruction have a better outcome as compared to multiple obstruction and multiple sites or a long length of obstruction. And greater success is achieved with stenting primarily in these situations wherein there is an obstruction within with some type of compression on the lumen so that they can be opened up. Now, this is medical management remains one of the important components for palliative care patients, and depends upon whether patient has partial obstruction or complete or refractory obstructions. In case it is partial obstruction, some amount of NPO with judicious fluids with or with not NG tube, which may not be required for all patients. Providing them good analgesia, we can start them on antiemetics when there is a partial obstruction. The use of prokinetic agents remains one of the good options. Metoclopramide can be started. Even ondansetron can be added in these patients. If they are having refractory nausea, haloperidol can be added as a rescue measure. The use of anticholinergics are primarily to reduce the secretions, and we can use agents like scopolamine, or at times octreotide can also be used, but since it is a little costly one, so the scopolamine may be an acceptable one. The addition of steroids has a definite role. It is not only an antiemetic, but has an anti-inflammatory effect, can relieve the obstruction in these patients who has partial obstruction, and can improve the nausea vomiting. But in case it is a complete obstruction, no prokinetics are required for these patients. Give them a good analgesia, give them good anticholinergic agents so that the secretions decreases. Steroids can be added, and then we can consider what other options, including either it is a surgical management, or if it is patients of end-of-life care, we can manage them accordingly. Octreotide is one of the drugs that are being used in these patients when they have intractable vomiting. It is not considered as an anti-nausea agent, but it reduces the occurrence of nausea vomiting by its action on somatostatin receptors, and that leads to decrease in the GI secretions and the peristaltic movement, and thus decrease the obstructive symptoms leading to relief of nausea vomiting. The dose that usually are being used is subcutaneous infusion of 100 to 150 mics, can be repeated every 6 to 8 hourly, or it can be given as an infusion of 0.2 to 0.9 milligram a day as a continuous infusion. Patients with advanced cancers, we can think of combination of using of all those drugs as such for these patients. And as I mentioned, the combination of drugs would be required with this bowel obstruction. So having said that, we realized that there is no fixed management for our patients with nausea vomiting. We realized from this case of Mrs. X of CA lung, CA breast, that the various etiologies happens in the journey of a cancer, and hence this emphasizes the need of assessment and reassessment of the patient and modification accordingly. So use the drugs as per the underlying etiology, which may not be always same and can change with the patient's journey with cancer. If a patient is not responding well, we need to look for the reason, whether it's the one or multiple mechanisms, whether the dose is inappropriate, whether the patient is not having good absorption of the drugs, we need an intravenous run, or the diagnosis is complete, and whether the patient is having a good compliance with the drugs. And simultaneously, patient needs to be given a realistic hope so that anxiety factors remains well. Now, when we say these are the good papers where they mention, this is just not the patient compliance, but it was found that the clinician adherence to the use of appropriate optimal therapy remains a basic issue where these patients are receiving some type of cancer management. So even the clinician needs to be very, very clear. For intractable nausea vomiting, you schedule your antiemetics round the clock till it is controlled. You use polypharmacy, choose the drugs appropriately based on underlying etiology, and try to rule out the underlying lesion by subsequent assessment or investigations as required. And based on this, we can add on the haloperidol, which has action on multiple receptors. Similarly, the olanzapine again has action on multiple receptors. They are acting on various receptors, and that's why the use of these drugs has found a role in patients with persistent or refractory type of nausea vomiting. Olanzapine is an emerging drug, found a role for nausea vomiting in palliative care setting, a paper from our center also, and there are a couple of papers which has found a good role of use of olanzapine, not only just in chemotherapy-induced nausea vomiting, but also in palliative care settings. And this is a good review where they have found that it can be used as a therapy where patient has multiple etiology or is refractory. It's an atypical antipsychotic agent. It acts on multiple receptors, including acetylcholine, muscarinic, dopamine, histamine, and serotonin. So this emphasizes that even if there is underlying multiple etiology, the use of these drugs as a part of combination therapy, even for highly emetogenic potential chemotherapeutic agent or patients having multiple etiology with advanced cancers, this drugs remains one of the acceptable drug for optimal management of nausea vomiting. But side effects needs to be remembered is fatigue, drowsiness, sleep disturbances that can happen. So be careful for these patients. Now, olanzapine, this is a good review again, which has confirmed that the usefulness of olanzapine is primarily because of its effect on many receptors, and its tolerance profile is good, safety profile is good, so can be used for other drugs. Similarly, the aprepitant, which again is finding a good role in not only in chemotherapy, but also finding role in other type of palliative management and can be used. This is an NK1 receptor antagonist. It has a novel mechanism which is in synergistic with the serotonin receptor antagonists and steroids. And primarily it is being used for chemotherapy-induced nausea vomiting, but finding increasing reported role in other type of palliative care setting. The various molecules of aprepitant is available. Usually aprepitant starts on 125 milligram once a day, and then 80 milligram can be repeated subsequently to have a sustained effect. Having said that, these were the pharmacological management, but yes, non-drug therapy are also equally important for these patients because central response or the cerebral cortex response is also there. So we can use behavioral approaches like relaxation, imagery, distraction techniques, music techniques for the patient comfort. Especially in GI-induced irritations or the chemical irritations, the dietary measures are important. We can have an environment where the gastric irritation is reduced and the chances of nausea vomiting will be much better. The use of acupuncture and hypnosis may also have some role in as an adjunct technique, and they can be added on to the pharmacological therapy. Remember, symptom management in palliative care setting is important, but the associated side effects are equally important when we use these agents, and hence we should be careful so that the compliance of this drug itself may not be hampered with associated side effects. So we should be looking for various side effects like sedation, extrapyramidal symptoms, anticholinergic side effects, delirium, orthostatic hypotension, or some cardiac changes. So we should be careful about these side effects and manage them accordingly so that patient is not harmed. Also, the patient compliance remains good. The other known cancer nausea vomiting can also be seen in palliative care settings like in cardiac failure, COPDs, renal failure, dementia. The underlying etiology needs to be controlled. They cannot be treated. They needs to be controlled, and then depending upon the manifestation, the use of drugs like 5-HT3 antagonists or steroid, or even the emerging role of the olanzapine is founding some role, some reported role for its use in such type of known cancer-related nausea and vomiting. We also need to manage in the cancer setting the use of metabolic abnormality like hypercalcemia, the gastric irritation, the cough which can happen in nausea in case of COPDs, and constipation. These are the usual reversible causes that must be attended when these patients are coming with nausea vomiting. So to summarize, these various the factors or the sites which leads to nausea vomiting like chemical, impaired gastric emptying, visceral, cranial, vestibular, cortical, based on their receptor target, we can start them on therapies, and if required, we can add on therapies which will be as a rescue measure. We can use a combination of therapies in the beginning and then taper off them at the earliest so that patient have sustained relief of the nausea vomiting. So to summarize, nausea and vomiting may be due to primary disease, the treatment sequelae, or the coexisting disease. And the key to effective management of nausea vomiting is through proper assessment and identifying the underlying differential diagnosis to establish or to look for a reversible cause and manage them, and simultaneously adding on the antiemetic agents so that patient gets in good control of nausea vomiting. Where M-Esis limits antiemetic drug absorption, the use of parenteral route should be considered, in addition to the other drugs which are being taken up by the patients, especially like analgesics. They may also be required to be converted to parenteral for some time till the nausea vomiting is taken care of, and then these drugs can be converted to oral therapies and tapered off as and when required. Thank you so much.
So thank you, Rakesh, for an excellent presentation. I think it was a very good overview where I think people must have learned that mechanism based, it's so important to use drugs based on the mechanism. So Arun, there are a lot of questions. So go ahead with the question answer and then we will summarize.
Yes. Thank you.
Yeah.
Rakesh sir, the first question is, do you always prescribe a PPI or H2 blocker along with dexamethasone or NSAIDs? And what is the evidence?
Right. So as we talk of the evidence with regards to the drugs of PPI and H2 blockers, when we use an NSAID for an extended period of time, depending upon the assessment, the addition of PPI remains one of the acceptable method for NSAID-induced gastritis leading to pain. So the addition of NSAID, addition of PPI would be an acceptable method, acceptable regime for its use with NSAIDs, especially when you're using etorocoxy or something like this. And similarly with dexamethasone, obviously, because when we are adding on, starting on the drugs for nausea vomiting, like dexamethasone for nausea vomiting or pain management, the initial trial of addition of these drugs is always a good option. And when we are tapering off these drugs like dexamethasone and tapering or dose, then you can also taper off and stop these PPIs or H2 blockers so that we are not giving multiple polypharmacy for these patients.
Okay, thank you. So the next question in the chat is that sometimes patients on chemotherapy get ondansetron, as you said, for chemotherapy-induced nausea, vomiting, and same time for pain. During that time, they're given morphine. So how do the things kind of take place as far as interaction is concerned? Can we use ondansetron morphine together in this setting, and then what precautions should be taken?
Absolutely. I think this is a very good question. And if you see the couple of years back, maybe 3-4 years back, if you see the discharge summary of medical oncologists, they were primarily using 5-HT3 antagonists, initially with ondansetron, and then they had granisetron and palliative being longer acting agent. But if you see the recent updates and the emergence of the drugs, people are more going change to aprepitant and olanzapine as a first-line therapy for highly emetogenic potential. As I mentioned in one of my slides, the use of 5-HT3 antagonists for long duration have effect on constipation. And when we're using opiates, it can further precipitate the constipation. That is a big issue. So in case if it is mandatory to use, we should be cautiously and prophylactically use laxatives so that patient does not have constipation. But the trends are changing. The 5-HT receptor antagonists are being replaced or primarily being supplemented by the use of NK1 receptor antagonists along with olanzapine as the first line therapy, and then we can continue them. But yes, if they are being prescribed with drugs like ondansetron or palliative, we should be very cautious when we are using morphine. Give them a prophylactic laxative, advise them a good amount of oral hydration and mobility so that they do not land up in constipation.
Okay, thank you. There are a few other questions like, is scopolamine available in India?
Scopolamine patch was available some time back. It is the patch formulation is available. Scopolamine injections are also available. They are not freely available. They are very restricted at some centers. They are at some places they are available, but they are available at restricted areas. So if possible, I think you can keep one or two ampoules or a patch for it for use of these patients, because this remains a good alternative for a costly drug, octreotide, which is being used for bowel obstructions. So this is a costly drug, not usually available in a palliative care setting. So this remains a good alternative, but not easily available.
Okay, thank you. Next is from a student, Vikas. He's asking that DEXA is used for increased ICP, and if someone has diabetes, then what is the way we should manage DEXA? Shall we decrease the dose of DEXA, or what shall we do?
Absolutely, a very, very interesting question, because when we are talking about the management of nausea, vomiting, these patients do have comorbidities. So we have to, whenever we use any drug therapy for management, we should always be looking for the risk-benefit analysis. So when we say a risk-benefit analysis, if patient is having an increased ICP based on clinical sign, giving a single dose or achieving a short duration of steroids will not lead to much derangement in the sugar levels of a diabetic patients. But giving a steroid will be beneficial for this patient, because patient may be taking on oral hypoglycemic drugs. If he having nausea, vomiting, they may not be absorbed appropriately. That again will lead to derangement of blood sugar levels. So we need to start them on steroids if there are definitive indications for it. And if the steroids are hampering the glucose control, for transient measures, we can just monitor the patients and manage them appropriately and try to taper off the steroids at the earliest. Also, we need to remember that the steroid therapy, there's something called a steroid trial. All patients may not respond to steroid every time. So in case if a patient is not responding, we need to
Can you mute the mic, Nisha?
So
You have muted Dr. Rakesh mic also.
I'll unmute now. So in those situations, you can stop the steroids and think of the other alternative therapies. As I mentioned, we can use radiotherapy, because same day, the start of radiotherapy will have its effect on next 2 to 3 days, and then we can taper off the steroids also.
Okay, last question, sir. So it's about haloperidol. Do you use haloperidol prophylactically for morphine-induced nausea, vomiting, and what is the starting dose of haloperidol?
So the addition of the morphine or opiate-induced nausea, vomiting is not prophylactically. It depends upon the patient's manifestation. It can be either SOS initially, or in case if a patient is having a say persistent type of nausea, vomiting, then it can be added as a regime of management of pain along with nausea, vomiting. Usually we start with 0.5 milligram of oral haloperidol as an HS dose. In case if patient is having active nausea vomiting, these patients are usually admitted because the oral absorption may not be good. Haloperidol is also available in an intravenous preparation. At this point of time, the patient is administered not only haloperidol, but also analgesics as intravenous dose, because we mentioned that the patient who are having cancer pain, the pain itself can lead to nausea vomiting because the associated anxiety. So these patients may require short duration, maybe a day or two, with intravenous analgesics, intravenous haloperidol, or in addition, if required, we can use some metoclopramide. And once the nausea vomiting is controlled, then we can continue for some time, say a week or so, and try to look for the underlying cause. If it is exclusively opiate-induced nausea vomiting, we can think of, depending upon whether patient is responding or not. If it is because of other associated factors, sometimes, like for example, we have started them on NSAIDs, or there is some issues with the bowel activity, they also needs to be acted simultaneously. So it does not have a prophylactic role as such. It depends upon patient manifestation. If patient responds, we can stop it. If patient has persistent, we can continue for longer duration.
Okay, thank you. I think we have a very good session. Sushma madam, please take over.
Yeah, we have very good, excellent session, and I think we can see a lot of compliments to you, Rakesh, in the chat box. And we have overshooted time also, but there was a lot of questions, and I just want to add one more thing. In the question which Vikas has asked, the diabetic patient with steroids, I think when steroids are important to give, for example, in cranial or brain metastasis or spinal cord compression, we have to give, and we should give. Only thing we can change the sugar by giving insulin. So Rakesh has said that we, whenever there is importance, we have to give, but we have to simultaneously record the blood sugar very frequently, and we can change the sugar by giving insulin, so that insulin will remain managed, but steroids should be given. So now, thank you very much, Rakesh. Thank you, Nisha, for keeping all of us on track. She keeps on sending reminders so that people should get up early. Thank you, audience. I can see more than 100. I think total it was more than almost 100 people have joined, even on the holiday Guru Nanak Jayanti. It was so heartening to see that so many people have joined this class, and it was an important class. All classes, those who are happening, are excellent classes, especially for the beginners. I request that all the people, those who are attending as a faculty from various departments, those where MD students are there, I think they should encourage their MD students that they should definitely join, because no one is going to teach them a topic like whole topic in 1 hour. So they will not get this opportunity. So they should definitely, MD students and youngsters should definitely join. Now next week we will see you all, and we will see you before 6:30 with again an interesting topic, how to manage a patient who is constipated. So see you all. Have a good week, and happy Guru Nanak Jayanti. And again, I will say that we are with Dr. Lulu, and we pray that she will have a fast recovery from grief, and we are there with her, and we want to see her as soon as possible in our classes. Thank you very much.
Thank you, ma'am. Thank you, Dr. Arun Ghoshal, for interaction, and thank you, Nisha, also. Thank you.
Arun is always there to moderate, and he is very balanced in which question he should take. Thank you, Arun. Thank you very much.
Thank you, everybody. Thank you so much.
Okay. Bye bye. Have a nice day.
Bye.